everyone. So we're here to talk about HIV with possible treatment failure, which is becoming more and more prevalent among our patients. We did a study about 3, 4 years ago, and we found that about 10% of patients fail treatment in the first year. And that's actually following with people who followed for a whole year. So if we put in yung dropout rate, which is about 20%, it really comes out to a much higher failure rate than that. So our objectives are really, we want to talk about this in a case-based fashion because it's really easier to learn with cases that we encounter in the clinic. So when do we suspect treatment failure? What is an HIV resistance assay? How do we start second-line ARV options? And how do we promote adherence in our patients so that they don't fail treatment? So the problem really with HIV is that it's one of the fastest mutating organisms on the planet. In fact, it mutates 100,000 times faster than bacteria. And part of the reason for this is because it's an RNA virus and it uses reverse transcriptase. Reverse transcriptase is a lousy enzyme in terms of proofreading, so it makes a lot of mistakes and it keeps mutating itself. Putting that into perspective, you have a patient who has about 10 to the 10th virions per day being replicated, and if you're mutating, you can actually mutate the whole genome several times a day. It's a real problem. On top of that, the viral genome is actually, you have 2 strands of RNA, and it can recombine when you have 2 different subtypes that are infecting a cell, and so they can recombine. They can have HIV babies. If we think about the role of antiretrovirals in our patients, if we look at the cell cycle, we've done really well in terms of looking for targets for stopping HIV in its tracks. And so, for instance, I don't know if you can see the arrow. You have your CCR5 receptor here, which we can block with like Maraviroc, and those CCR5 antagonists are also monoclonal antibodies that can do that. And then, of course, a major target is reverse transcriptase, which the virus uses to go from RNA to DNA, which then integrates into the cell. So we have nucleoside reverse transcriptase inhibitors. In the Philippines, this is zidovudine, tenofovir, lamivudine. We used to have stavudine. Thank God we don't use that drug anymore. And I think abacavir is available in limited supply. And then we also have non-nucleoside reverse transcriptase inhibitors, which still act through reverse transcriptase. And then we have integrase inhibitors, hopefully will come dolutegravir soon. And this prevents the HIV genome, which is already reverse transcribed, from integrating into our host cells. And then from there, the integrated viral DNA is transcribed into mRNA and then translated into protein, into one long protein, which is then chopped up by protease, which is also a target for our medications. And then there are also maturation inhibitors, which prevent HIV from being properly assembled and maturing. So we have lots of areas. So how does resistance develop? And part of the problem is that in somebody who has a lot of virus, there will already be mutated drug-resistant viruses, because remember that the virus is constantly mutating. Some of those mutants are actually defective mutants. In fact, 99.9% of the virus in someone who is not on ARV's blood is actually not replication competent, meaning that it doesn't really it can't really infect. So that's how bad the mutation is. But some of those viruses are replication competent and also have genes for drug resistance. And so, but every time the virus mutates, you end up with, every time it mutates, it comes at a cost to the virus, either in terms of replicative capacity or how well it can replicate itself, or also in terms of viral fitness. So it's not a very fit virus. So it's not good for the virus to be mutated. And so in somebody who is not on antiretrovirals, you'll have the minority of drug-resistant viruses, and then you have a majority of drug-susceptible viruses because there is no drug pressure. So if you have good ARV pressure, then it's unlikely that those drug-resistant viruses will be able to replicate. But if you're not taking your medications properly and there is some partial drug pressure, then you will select against these blue areas, these blue viruses, to the point that even if you then continue taking your ARVs, you have more and more drug-resistant virus, which then leads to treatment failure. So when we talk about HIV drug resistance, these are the definitions that are used by WHO. When we say acquired HIV drug resistance, this is HIV resistance that develops when you're on treatment. So somebody who's taking medications who has completely susceptible virus at the start, doesn't take their medications religiously, and you end up with drug-resistant virus. So that's what we call acquired HIV drug resistance, or ADR. And then the second is called transmitted HIV drug resistance in someone who has never received any ARVs. You know, some people can get suboptimal ARVs, lalo na somebody who has hepatitis B, and they get tenofovir, but they don't get lamivudine and efavirenz kasi tinitreat lang nila yung Hep B, hindi naman nila alam na may HIV yung pasyente. So you expose them to tenofovir, and that's suboptimal medication for HIV. So ang tawag doon is yung number 3, yung pre-treatment HIV drug resistance. If somebody has never been exposed to ARVs, ever, then that's what we call transmitted drug resistance, because that is a viral resistance that is transmitted from the person who infected them, who probably was on treatment and had acquired drug resistance. So linipat niya yung kanyang transmitted virus to someone who is completely antiretroviral naive. So yun ang tinatawag na TDR. So those are your answers for your pre-test. Medyo mahirap yung pre-test, no? I mean, I was looking at it like, oh, it's okay. You know, this is how we learn. So, and then pre-treatment HIV drug resistance. This is people who had prior exposure to ARVs. Again, either the tenofovir for the hepatitis B, or back in the day kasi in Africa, they used to give single-dose nevirapine to pregnant women at the time of birth to prevent maternal-to-child transmission. Unfortunately, that led to a lot of pre-treatment HIV drug resistance. So just to recap, ADR, or acquired HIV drug resistance, is the resistance that develops on treatment. Transmitted drug resistance is resistance that is transmitted from somebody who probably has acquired drug resistance to somebody who has never, ever seen antiretrovirals. And number 3 is pre-treatment HIV drug resistance, which is people who saw previous treatment with like tenofovir or single-dose nevirapine, or it's actually a bigger subset. It can also include transmitted drug resistance. So mas specific yung TDR na kailangan never exposed to drug, whereas yung pre-treatment pwedeng never exposed to drug or meron ring prior ARV exposure pero they stopped it. So this is the first case, 28-year-old male diagnosed with HIV in 2012. The CD4 count is 174. And then back then, we used to start zidovudine, nevirapine, and lamivudine without any problems. And then the patient was lost to follow-up after 1 year of treatment. And now he comes back to your clinic. He's been off meds for 3 months. He now wants to go back to ARVs and swears he will never stop them again. Sound familiar? I think we've all had this patient before. So what approach is the most reasonable in terms of managing this patient's ARVs? So do we check the CD4 count before resuming ARVs? Do we check the viral load before resuming ARVs? Do we send drug resistance assay before resuming ARVs? Do we start the old regimen? Or do we start a new regimen, tenofovir plus lamivudine plus efavirenz? Okay, so I think, you know, just, oh, okay, there's a question here. All right, great, sige. So go ahead and answer, and then submit, and then we'll see what happens. Is it going to come up?
Yes, sir. So I'm going to give them 5 seconds to answer. 5, 4. Answer po tayo. So about 35% have answered. Please click, everybody. Once we reach a substantial amount, we will launch it. Okay, 5, 4, 3, 2, 1. With 70% who answered, ito po yung sagot.
Okay. All right, the answer is letter D, and we'll talk about that. Okay. Let me see if I can get myself back. Okay. So, oops. All right. So, here are the explanations. So the answer is D. Okay, start the old regimen. Why is that? And again, it goes back to selection pressure for the patient. So if we check a CD4 count, yeah, you could do that if you want to, but you expect it to be lower because it's the patient's not been on the medications, but it's not a requirement for restarting ARVs at this time. Okay, so check viral load. It's almost certainly going to be positive because the patient's not been taking their meds. So mataas yung viral load mo. That would be an academic exercise if you wanted to see it go down from a baseline. But again, it's not necessary. Okay, so send drug resistance assay before resuming ARVs. And this is the tricky part because if you are off medications, there is no drug pressure. And as we said before, nagre-revert siya to wild type. So yung test kasi na ginagawa, yung genotyping, it can only detect resistance if 20% or more of the virus population has the mutation. Otherwise, it will miss it. So that it may detect it, but then again, it may miss it. So it's not the best time to do it. What you really want to do is restart the old regimen and then check another viral load in anywhere from, usually we say about anywhere from 12 to 16 weeks. It can go to about 3 months if you want. You can check it earlier if you really want to, especially with some of our more potent regimens. But if at 3 months and you recheck it, the viral load is above 1,000, then that's the time you can do drug resistance testing with the old regimen on board, so that you're fairly confident that the medication that the virus really is undergoing drug pressure. Kung undetectable siya, then you can continue taking your old regimen. That means that wala talagang resistance. Okay? Start the old regimen. Again, this is the correct answer because if you start the old regimen, you're not compromising anything that hasn't been compromised before, and it will help you determine if drug resistance is present by doing the viral load again in about 3 months. And you don't want to start a new regimen kasi for instance, resistant na siya to EFAB, resistant na siya to lamivudine. So nagmo-monotherapy ka with the tenofovir, and then you will lose tenofovir talaga kasi you don't have 3 active drugs and you'll end up with suboptimal therapy. So the bottom line is you want to start with the old regimen so that you can check if it's still good or not. Repeat the viral load at 3 months. If the viral load is greater than 1,000, we do drug resistance testing. If it's suppressed, then you just continue your medications and there is no resistance. Okay, so when we talk about drug resistance assays, there's 2 types. There's genotypic and phenotypic. We don't have phenotypic in the Philippines. This involves fusing the virus with the simian virus and doing a lot of lab assays. We don't do that here. What we really have is genotypic resistance, where we sequence the virus. It's available in 2 places, RITM and also here in NIH. We use the mutations to predict drug resistance, especially for NRTIs and NNRTIs. To a certain extent, it's okay with protease inhibitors, but sometimes they don't necessarily match. So when we do genotype testing, we actually just amplify part of the virus, the reverse transcriptase gene and also the protease gene. So we do that. We do a PCR, we do sequencing, and then again, it will detect the mutation if it's in about 10 to 20% of the virus population. This is more likely if you are on treatment. If you're not on treatment, then it's plus minus. Sometimes you'll find it, sometimes you won't find it. There are other methods. We've been doing deep sequencing, but it's not ready for prime time yet. And deep sequencing is about 50,000 pesos per sample, so we're probably not going to do that yet. But we're working on it to get the cost down. So this is just what the resistance patterns look like. It looks intimidating, but all this really is, so this is a gene. So for instance, we look at tenofovir. One of the most common mutations is K65R. So that just means it's the 65th position on the reverse transcriptase gene, and there is a codon mutation that turns K into R. Those are the amino acids. Don't ask me to remember what these stand for, but they are amino acid mutations basically, and that causes high-level resistance to tenofovir. One of the most common is something called M184V, and that's a lamivudine resistance mutation. Again, it's in the 184th position. It turns the methionine into either valine or isoleucine. and that causes resistance to lamivudine and emtricitabine as well. So that's how we report the mutations. For NNRTIs, efavirenz, etravirine, nevirapine, we also do doravirine um, and rilpivirine. You can see that there are certain mutations here that are across the board. So for instance, for efavirenz, if you have a K103N in efavirenz, it also makes you resistant to nevirapine, K103N, but not to etravirine. We see a lot of Y181C rather than K103N in the Philippines, and you can see it really takes out etravirine, and it also takes out rilpivirine. Okay, so again, going back to the concept of wild type, we want to make sure that there is drug pressure on the virus before we do the drug resistance test. Otherwise, it may miss those resistance, and it'll just come out when you restart your medications. And we talked about restarting the old regimen. Okay, so how do we know someone is failing treatment? Okay, so the earliest indication that someone is failing treatment is a non-suppressed viral load. So what we want is a 1 log decrease. So if from 1 million copies, dapat maging 100,000 copies na lang siya after 1 month of ARVs. And we expect that at about 3 months, dapat less than 1,000 copies na or suppressed na yung patient. If we don't reach those goals, that means there might be resistance going around. The problem is we don't do baseline viral loads. So how can you say it's a 1 log decrease? We're starting to do that in PGH where we're doing baseline viral loads and doing a viral load at 3 months just to see if we can catch the resistance and how much resistance we're going to catch with that. So look for that, for the result of that research in the next year. Decreasing CD4 count is a late presentation of treatment failure because you're already starting to have a lot of viral replication and immunologic failure. And the last indication of treatment failure is your patient is progressing clinically from in terms of the WHO stage, or you're getting opportunistic infections, or just getting wasting disease and getting worse and worse. So the patient's old regimen of Zydo and Lami and nevirapine is resumed. After 3 months, viral load is 50,000 copies per ml. Drug resistance genotype is sent, and it shows M184V, which shows resistance to lamivudine. It also shows K103N, which is resistance to nevirapine and efavirenz, and there's no drug resistance mutations among the protease inhibitors. Okay, so what's the best regimen for this patient? No change until we get another viral load after 3 months. Or do we shift to tenofovir plus zidovudine plus lopinavir-ritonavir? Take note, if you don't have freestanding Zydo, you'll end up using Zydo-Lami-Teno, which is okay because it mutates it into a more hyper-susceptible version of Zydo and Teno. We shift to tenofovir plus Zydo plus efavirenz. Because the efavirenz resistance is spurious because the patient's never seen efavirenz. Okay, you want to answer?
Please answer the poll, and the poll will end in 10 seconds. 10, 9, 8, 7, 6, 5, 4, 3, 2, and 1. With the 70% of answers, here are the results.
Okay. All right. Great. So the answer actually is B. Okay. There's no point in getting another viral load in 3 months because your patient already failed treatment. So it's really Teno, Zydo, Lopi dito. And you don't want to give efavirenz because there's already K103N. And so when you have K103N, this is why we say NNRTIs have a low barrier to resistance. Kasi isang resistance lang, you knock out almost all of the NNRTIs, which traditionally has included efavirenz in the therapy. So don't use efavirenz kung may K103N, Y181C, Y188. Those mutations are pan-NNRTI mutations. It's kind of like in antibiotics, kung resistant siya sa penicillins. Parang ganun siya. So the answer is Teno, Zydo, Lopi dito. And there's a few caveats here. Again, if you don't have freestanding Zydo, it's okay to keep the lamivudine on because it keeps the 184V, which gives you hyper susceptibility to Zydo and to tenofovir. The lopinavir-ritonavir, there's two ways to take lopirito. It's 4 tablets once a day or 2 tablets twice a day. In patients who are treatment experienced, you should usually use 2 tablets twice a day. Sa treatment naive lang yung pwede na 4 tablets once a day. Oops, why is there I don't know, so something came up on my screen. Anyway, again, so there's no change, there's no point in waiting. If there is something called a blip, and a blip is where you have an increase in the viral load. It's usually just below 1,000 copies, and then you can recheck, and then sometimes it just goes back down. But if it's 50,000, tunay talaga yun. Okay. Now, this is the correct answer. Again, we want 3 active drugs as standard of care for second-line ARVs. There's more and more data that some 2-drug regimens may actually work very well, and that includes dolutegravir with lamivudine, and also NRTI-sparing regimens like doravirine with dolutegravir, I think. The bottom line is we're not there yet here in the Philippines because our drugs right now, our standard is that we have to have 3 active drugs, 2 NRTIs, and 1 other agent. And in this case, it really should be lopinavir-ritonavir because we've already compromised our NRTIs. Again, retaining lamivudine is okay. It's not harmful. And then Teno, Zydo, efavirenz, you don't want to do that because K103N confers high-level resistance to NNRTIs. So efavirenz will not work. And the reason why we don't like NNRTIs is because it has a low barrier to resistance. Okay, so take-home points. Resistance testing should be done with the original regimen on board to ensure that the resistance mutations can be detected. Always make sure that there are 3 active drugs, 2 NNRTIs, because either an active NNRTI or PI. Now, I know that we've had patients who only have 1 NRTI left. And that's a real problem because eventually the PI will fail. Hopefully we can work with our ITM and DOH in trying to get a 3rd drug that's active. Usually an integrase inhibitor would be great if we can work with them to get those drugs so that we have 3 active drugs. Okay, so case 2, 35-year-old male diagnosed with HIV in 2013 with CD4 count of 287 cells. Co-infected with hepatitis B, started on tenofovir plus lamivudine plus efavirenz 6 months ago. Repeat CD4 count is 198, and subsequent viral load shows 20,000 copies. So on further questioning, he recalls that he was given entecavir by a doctor in 2008 for 1 year, but he stopped due to the cost. At this point, the correct course of action is: do we stop the treatment and send the genotype, continue treatment and send the genotype, or add entecavir to his regimen and send another viral load in 3 months?
Ten seconds. 10, 9, 8, 7, 6, 5, 4, 3, 2, habol pa po, and 1. With 75% answering, these are the results.
Okay, great. I think we made a good impression with the last question, Kate. So that's good. All right, so absolutely continue the treatment and send the genotype. See if, all right, there you go. So if you stop treatment and send the genotype, then you're actually going to end up with more resistance because it takes a while to get the treatment back. And what you want to do is, the other problem is efavirenz lasts a lot longer than Teno and Lami, so you're going to end up with virtual efavirenz monotherapy. So whatever you do, don't stop the medications if you're already on them because the continued drug pressure still makes the virus less fit. Okay? And besides, na-expose ka na dun sa suboptimal regimen. So, you might as well make sure that it's working or not working. And you don't want to add stuff blindly either because you compromise even more. So continue treatment, send the genotype. So just keep it on and then send the genotype. Hopefully we'll get it back to you in 2 weeks with a recommendation. And then we can adjust the ARVs depending on the resistance pattern. So there's no point in adding entecavir because you already have the best drug on it, which is tenofovir. So tenolami is the best regimen that you can give for hepatitis B. In fact, the entecavir is probably the culprit. This is one case of pre-treatment drug resistance, most likely, because entecavir can cause M184V mutation in HIV and causing lamivudine resistance. So this patient likely is a pre-treatment drug resistant patient and would have benefited maybe from baseline genotyping. Okay, so drug-resistant genotype returns with the following results. We know it's M184V, and in RTIs, no drug resistance mutations and no drug resistance mutations to PIs. So aside from continuing tenozidovudine, what's the best additional drug for this patient? So do we add nevirapine because efavirenz is compromised, or lopinavir ritonavir because efavirenz is compromised, or do we maintain the efavirenz?
Okay, sir, hindi ako nakagawa ng poll dito. So, sagutin lang natin siya.
Yeah, all right. Just answer it in your mind. And the answer is just maintain the efavirenz because you already have the drug resistance assay, and you already have drug pressure for that. So most likely hindi siya resistant to efavirenz. Hindi siya resistant to efavirenz. So nakalusot ka. What I would probably do in this patient, in addition, is if they can afford it, I would probably check another viral load in 3 months just to make sure na wala talaga. So there's no reason to switch from efavirenz to nevirapine. So there's no evidence of resistance. So you caught it early. So again, you already have a drug resistance. You already have a drug resistance panel genotype, and so there's no reason to do that. There are situations where I would look at the efavirenz very suspiciously, and that's if the patient is not adherent, because then baka wala lang drug pressure, lalabas yung hindi lumabas yung efavirenz. Pero if you can say with 100% certainty that this patient is absolutely compliant and adherent to his meds, then you can safely say that efavirenz probably is still okay. But I would probably do that viral load at 3 months just to make sure. Kasi minsan nagtatago pa rin yung efavirenz na yan, lalo na with suboptimal treatment. In general, kasi ang NNRTI mahina talaga. So this is a situation where as long as you are fairly sure the patient is taking the medications and you have adequate drug pressure, you can probably continue with the efavirenz. But if you have any doubts, then the correct answer is go with the PI. All right. So we already talked about that. So the drugs that can induce resistance to HIV that they use for treatment of Hep B is lamivudine, clevudine, tenofovir, or entecavir. But it's highly unlikely naman that tenofovir will cause M184V. It's usually lamivudine and clevudine. Although it can, but it's more K65R. So how do we increase adherence? So we really like simpler regimens, 1 pill a day. And this is why I always tell patients, this is the best possible pill burden that you can have. So please take your medications. I mean, just try to motivate people so that they don't have to take other things. And hopefully the new regimens that are coming will also be 1 pill a day, the dolutegravir-based regimens. Pill boxes can help with multiple meds. You can do recurring reminders, alarms. Once a day regimens are still great. We can't really give protease inhibitors with lopinavir, ritonavir once a day right now. The reason being most of the time we're using it as treatment, salvage or second line treatment. Medication buddies help, also reinforcement, pill counts at each visit, although I know people dump their pills sometimes just to make it look like they're actually taking them. So also be wary of that. And then just explain to your patient, buhay mo yan, it's, we're all adults here, and you really need to try to motivate yourself. So if you're going to send a genotype assay, you can send it to us. It's a red top, 10 cc of blood. You can submit it up to 8 hours after the draw as long as it's kept on ice or refrigerated. It's 4,500 at VPNIH. We'll try to get it back to you in 2 weeks. And then, if you can give us a little bit of ARV history, that'll be best. just so that we can better address whether this patient's on treatment or not. We're getting more and more treatment naive samples nowadays. So in terms of trying to interpret that, iba, if you guys have gotten some of the results we've sent back, merong parang choose your own adventure. If this patient is treatment naive, this is recommended. If this patient is treatment experienced, this is what it is. So it would help us if you could tell us whether the patient is treatment naive or not. Because we're seeing drug resistance, transmitted drug resistance already, even in treatment naive patients. And that's the phone number over there for Sagip, actually, so we can coordinate the specimen drops. And we also have a way to receive it from the provinces right now. I think we're getting samples from Chongwa and even from Davao. So if some of the provincial hubs want to send to us, we can work that out as well. Just to show you a poster we presented about 3 years ago, you can see that the resistance rates are climbing, especially to NNRTIs. Also, tenofovir resistance rates are pretty high. Here, I'll show you. So the important conclusions in this study, it's still mostly the new Thailand strain and not much B showing up in the Philippines. Drug treatment failure at 1 year of antiretrovirals was 10.3%. The scary thing is that 57% of that 10.3% doesn't have a effective second-line regimen of 3 drugs. So kailangan talaga natin ingatan yung meds natin. Part of the problem is we're checking viral loads at the end of 1 year. So kung nag-fail na yung pasyente at 3 months, hindi pa natin na-detect, we're giving them a failing regimen for a whole year. So nag-accumulate yung resistance mutations. We end up losing meds. So if your patients can afford it, I would actually recommend checking a viral load at 3 months. I know it's not something that PhilHealth will pay for at this point, but it seems pretty clear to me right now based on the data that we're seeing that there is value in checking a viral load at 3 months. You don't have to check a baseline viral load or a baseline genotyping if you don't want to. If I had to pick, I would probably take that 3-month viral load at the start. But if you can do everything, it's great, especially for Sagip patients right now. There is a program to get that done. Right now I would probably recommend baseline drug resistance testing and then a viral load at 3 months. And it's weird because we thought tenofovir was a really, really good drug, but apparently AZT did better in the 1-year study. You can see that the treatment failure rate was 12.6% for AZT, FAB was 3.9%. If you have any patients who are still on tenofovir and nevirapine, please check a viral load. Ang taas ng resistance, ng failure rate niya, it was 29%. So it's probably better to get them off that regimen and put them on tenolami, efavirenz at best. I don't want people to start switching like crazy to AZT because of the side effects. So this is with a grain of salt. This is one cross-sectional study, but it does suggest that tenofovir doesn't work as well as we hope it would. And I would probably still not use AZT for first line just in terms of a side effect issue because it's also harder because it's not single pill. This is just food for thought that there is resistance to tenofovir that's more than expected compared to other genotypes out there. I still think we should use tenolami, FAB as first line, but then we should probably monitor closer for resistance until we have other regimens. Because AZT is just too toxic to be using as first line right now. And just to show you, it's not clear here, but itong blue na to sa K65R, that 7% is the resistance in treatment failures among in world literature. Yung sa atin yung orange, it's 39%. So mataas talaga ang tenofovir resistance natin. So again, it's something that we have to keep an eye on. Transmitted drug resistance, I can show you some of this data. We presented it about 2 years ago. We just finished crunching the numbers again. This is what it looks like. So for Sanger-based sequencing, transmitted drug resistance natin is 10.9%. So NNRTIs, it's 7.9%. Mataas yan. So you can expect about 7.9% of your patients will fail treatment within about 3 months. For NGS, ito yung sinabi ko na ubod na mahal, greater than 5% cutoff, which is kind of the standard. Ang transmitted drug resistance natin is 21.8%. I don't know what that means yet in terms of treatment failures. We're continuing to follow that cohort. But the one above, yung Sanger-based sequencing, that's real data. So we're above 10%. So baseline resistance testing is reasonable at that level of transmitted drug resistance. So in summary, resistance to ARVs is emerging. Know the clues to resistance. Check out your viral loads. Order genotyping test appropriately, including continuing old regimens before testing. If the patient had previous Hep B treatment, it's a clue to possible pre-existing resistance. Genotyping may be appropriate at baseline. The other thing is when you're switching patients off failing regimens and they have Hep B, don't switch them off the tenofovir. Nakasulat yan lahat sa mga binibigay ko na recommendations drug resistance testing. Kasi even if they're tenofovir resistant but they have Hep B, keep the tenofovir on. Otherwise, baka mag-flare sila. So that's on top of everything else. And then when you're in doubt, consult the colleagues. We're always here. Kate's here. We're all here. You know, this is a very collegial body. We're happy to answer questions. And if we have questions as well, we'll bring them to you as well. And you know, we really need more treatment options. So dolutegravir hopefully will get here soon. That's it. Thank you.